Kevin, thanks for joining me. So I'm really would love to kind of get into a little bit about how you got started in your career, and you're involved in pain management, correct? And how did you gravitate to that?
Yeah, so Jeff, so I started in pain medicine 10 years ago when after I finished from PA school. And back then it was a mission of mine and to be in pain medicine so that I can help others deal with their health issues. As far as pain, pain is something in life that nobody really ever escapes or avoids from. Whether it's from a minor pain such as an ankle injury or pain from things like terminal illness treatments, it is very difficult, and the pain experience is something that nobody ever wants to go through. So when I started PA school, I really wanted to see how I can make a difference in helping people in terms of the pain and suffering components of it. So naturally, pain medicine was the right place for me to be after I graduated from PA school. And Jeff, so what about you? What made you decide to go into hospice and palliative care medicine?
Yeah, I think for me, actually, I had always intended in being in primary care, and I did an elective with an amazing PA who has been my mentor, who did palliative care, and that was where I first got exposed. And I think part of what has attracted me to that field is it really does look at the patient from like a very holistic viewpoint. And every patient is a little bit different. Every disease state is going to be experienced by them differently. And palliative really, whether it's, the plan is they get a serious diagnosis or an illness that they're diagnosed with, or even a really bad injury, they may recover, they may survive, they may be cured, but they're going to have difficult questions about their treatment, their processes, difficult decisions to make, probably are going to have symptoms along the way. And for those that their disease may be terminal, they're going to need that support. And I just find that that's a kind of a hole in our health system and in among the all specialties and some of the training even, that they need someone that's going to be able to set and spend more time focusing on those things, symptoms, difficult conversations. And for some reason, I don't mind doing that. So,
Have you encountered many patients with substance use disorder who are in recovery in your practice?
Yeah. No, I definitely have, and I have definitely noticed an increase in recent years as well. I think, one of the things that happens is people with opioid use disorder, people with substance use disorders, they all have the potential to get a serious or life-threatening or terminal illness. And one of the challenges, especially for those that are in recovery, they feel like they've beaten that part of their journey in life, and then they get hit with this other thing, and they have legitimate needs for pain.
Why do you think this is an especially important and sensitive interaction?
Yeah, well, I mean, I think both topics, end of life, serious illness, making really tough decisions, and then opioid use disorders, substance use disorders, they're all really kind of situations and conversations that we tend to shy away from as providers, but also as patients. And so I think it's ultimately important that, especially when those two kind of interact, like palliative and opioid use disorder do at times, you really need to spend some extra time, do some extra work. As I said, they have been on a difficult journey already, and if they're in recovery, they may be really like, I don't want to screw this up by needing to take pain medicine for my cancer that I have. But at the same time, I want them to have a quality of life. I want them to be able to function day to day, and an opioid may be appropriate for them. And so we have to work and find a safe way to do that, the right opioid, the right other management and other modalities to help them. Yeah, and I guess, Kevin, too, when you've worked with patients in recovery, have you experienced those who may be facing a terminal illness? And, what about those patients in recovery who are maybe caretakers or facing a loved one with a terminal disease?
Yes, Jeff. So throughout my years in pain medicine, I've encountered many patients in that situation, patients who are recovering from opioid misuse and is also dealing with a terminal disease. those people are definitely in a tough situation because of their tolerance to medication, as well as their coping mechanism dealing with a terminal illness. So that definitely makes it harder to help those patients. And as far as patients with a opioid use disorder background who is recovering and is also acting as a caretaker or is caring for a loved one, certainly they too can experience a high level of challenges, because what we know is that patients who are recovering from opioids, they themselves have to try to work to curb their cravings so they do not relapse. So when they do help out with another patients who are using opioid therapy, they're being exposed to it. So that exposure, along with the added stress from caring for someone who is ill, that makes it that much harder for them to maintain their opioid recovery maintenance.
Yeah, no, I can definitely relate with, the experience of treating those patients in recovery and having a serious illness or caretaking. What strategies do you have for those that are in recovery who may need more help with their pain management? What kind of things are your go-to?
Right, Jeff. So certainly there are ways to help out with those populations as well, because they do need help just like everyone else. So patients who are considered high risk, whether it's from their past opioid use disorder, then that just means we need to take more precautions whenever we take care of those patients. That could mean including more screening tools, monitoring them with more things such as urine drug screens, or even having a closer durational follow-up so that we can continue to assess how they're doing and if they need any help. It's best to identify patients whenever they go through a tough time and do that earlier rather than later. So those are some of the things that we can consider whenever we're taking care of someone with a higher risk level for relapse. So Jeff, you must have also seen patients and caregivers struggling with opioid misuse. Tell us a little bit more about that.
Yeah, I think that it can be kind of a misnomer in palliative care, because so many of the guidelines and things that get put out, say, be really concerned about opioids for your patients that have non-malignant pain. Well, then the assumption is those that have malignant pain get a free pass, and it's just simply not true. I mean, we have patients with opioid use disorders that get cancer or some other serious illness. We have family members who are experiencing those things. And caregiving is such a big piece of helping take care of somebody going through a serious illness and needing help, getting to their appointments, taking their own medications. And as you noted earlier, those caretakers, if they are the ones experiencing an opioid use disorder or in recovery, we've got to worry about their cravings. I've also experienced, I live on the West Coast, and as in other parts of the country, there's a significant housing crisis and a lot of people who are facing housing insecurity, and prevention of opioid misuse in that population is really important. But their safety is also important. So prescribing them, hospices will often even require a lockbox for those patients to make sure that their medications are secure. We don't want them being harmed by someone trying to steal their medications or taking advantage of them because of their medications. And so there's a lot of different factors both within palliative and hospice that you have to take into consideration with not only your patients but their families. We're looking out for all of them, and that's part of what palliative is about, is kind of the whole person, including the family, their support systems and teams, and we can't forget about them.
So Jeff, now let's talk a little bit more about misconceptions. So I know the two populations that we are talking about definitely suffer from public misconceptions. So in pain management, one of the misconceptions that we have is whenever a patient has a history of opioid use disorder, then one of the concerns is that they will relapse again. So that definitely makes it harder for those patients to get adequate care. What are some of the misconceptions that you see in your setting?
As I mentioned earlier, those patients that are on palliative or hospice or, have a life-threatening illness, we tend to think they're excluded from all these guidelines and things that the CDC puts out, but they're also at risk for all these things. And so we do need to pay special attention. Anyone with an opioid use disorder can develop a cancer later on. Somebody without one, because now they have a cancer and are being for the first time exposed to opioids and other therapies, may develop one. And so, if their goal is actually cure, we want to make sure that they come out on the other side better off and not with a new opioid use disorder. So we definitely need to pay attention to that. And I think, as you noted earlier, we have patients that develop a tolerance. They maybe have had a history of opioid use, and so they may require higher doses than what some people feel comfortable with, and they're often on a lot of medications to treat a number of symptoms. And so that can put them also at greater risk for all those side effects and things. So you definitely have to spend extra time with those patients and really walk through making sure that you're not only keeping them safe, but the people caring for them as well.
And Jeff, in what ways do you approach patients who are in opioid use recovery different from the patients in your population?
Yeah, I think, ground rules for us are really kind of trying to really focus on the total pain. So their physical pain, emotional, spiritual, psychosocial, all those kinds of things need to get factored into this. And so we do that across the board. I think with our patients that are in recovery, we really want to kind of hear where they're coming from. What are their fears, about potentially trying to face pain, really hearing those out so we make sure we're addressing that and not just making assumptions. I think we definitely want to do screenings. We often use the opioid risk tool in our palliative populations. Sadly, there's not a lot of studies in this area because we tend not to think that they're as at risk, but they are. So we still want to use those tools that are useful in these other populations. And we want to also just spend time, helping walk through and making sure we're identifying if it's the anxiety, the depression of facing the serious illness that is causing some of their physical pain or even leading them to maybe some cravings too. Let's make sure we're addressing those appropriate with the right type of medications, making sure we're also treating the pain with the right type of pain medications that target that type of pain. So I think we do need to spend some extra time on some of the basics that we do, and I think that is not going to eliminate all risk, but it will give us a better spot to be able to identify when things do go wrong. So Kevin, as we kind of said earlier, these are all kind of pretty sensitive topics, and I feel like these are difficult conversations to have with patients. Sometimes that can be triggering for them. They may become defensive. They may even become angry. And we really want to try and maintain that therapeutic relationship with our patients. Do you have any kind of recommendations or tips or tools that you go to, your approach to having these difficult conversations and, really trying to connect and gain trust with the patient?
Sure, Jeff, there are definitely ways to talk to patients whenever the conversation becomes challenging. As far as tools, there are different tools like Spike's tool or nurses' tools that can be used and followed to make the process a lot easier. But from my own experience, to keep the situation under control, what I have done, and it works at least in my patient population, is to first keep the situation under a calm environment, so both patients and providers are not heated or angry. And then after that is to try to keep the whole situation professional, because we are in a professional setting. And then the next step after that is really to try to work out the situation. Every patient's situation is going to be different, and that's where we have to tailor our approach for that specific situation. But the way that I approach patients is mainly to talk to patients and also try to explain to patients in a way that they can understand about what the rationale is for the medical decision making. From a healthcare provider's point of view, our approach has to be evidence-based. So certainly that has to be the way that we approach our interactions with patients. So the challenge there is to help patients understand where we're coming from and why we're making the decision that we're making. And the overall goal is to tell patients that we are trying to keep them safe and we are trying to help them, but not at the expense of their lives. So as long as we try to deliver that message to patients and in a way that they can understand, I think that really increases their chance that they will walk away happier and more satisfied.
Yeah, Kevin, I think we have a lot of the same, concerns within palliative care in terms of communication. I think we also try and kind of meet them in the middle somewhere. And with, I think, just really trying to understand where they're at, providing that kind of empathy, trying to, acknowledge this is hard. And I think those are the best things I think that we can really do to kind of approach, setting down with those patients. And quite honestly, like actually physically sitting down, there's actually research that shows that if you sit down and have these conversations, they are actually received as more positive, more thoughtful, more caring than if the provider stands up and has the same conversation hovering over a patient. And so really sit down and let them know, like, hey, I'm spending time and I want to talk about this with you. And I want to hear if you're angry. I want to hear if you're sad. Let's talk about this and make a plan together. Thank you, Kevin, for joining me in this discussion. It's been really great talking with you today. I really hope our audience, can get out and kind of look at the different resources and really encourage them to look at the other segments on, this special, attention that we're paying to for preventing prescription opioid misuse in special populations.
Thank you, Jeff. I'm glad to be here.
Thank you.